Thank you for joining us today for this webinar on preparedness. I would like to begin by and pay my respects to elders past, present and emerging. I'd also like to extend an acknowledgement and pay respects to any Aboriginal and Torres Strait Islander peoples joining the webinar today. I'm Michael Lai. I'm the Deputy Secretary in the Department of Health responsible for aged care. We're all hoping, I think, to be moving to an environment where we can live with COVID-19 and managing it like we would other viruses and illnesses in our sector. But this does not mean that we can step back from maintaining our preparedness to respond to an outbreak. Public health arrangements are still in place in all states and territories, and we need to be ready to manage a case or exposure in line with those arrangements. So the aim of this webinar today is to highlight the main preparedness points that you and your organisation need to be aware of. With state and territory borders opening and more people planning to travel, it's a good time to provide a reminder about the importance of planning a response to an outbreak. We have a great list of speakers today. Janet Anderson, who's the Aged Care Quality and Safety Commissioner, Adjunct Professor Allison Mcmillan, who's the Commonwealth's Chief Nursing and Midwifery Officer, Helen Grinbergs and Jacob Madden, who are from my team in the Department of Health, looking after the COVID task force, and aged care provider Chief Executives Patrick Reid from IRT and Ian Thorley from Estia Health. The session today is going to start with some brief remarks from our Minister Colbeck, who's just joined us. And this will be followed by some high-level presentations from the various speakers. And we hope to have about 25 minutes at the end of the session for questions and answers. Just on the housekeeping, which is mainly around question and answers, you can use the Q&A function in the WebEx platform to ask your questions. If we don't get to all the questions that you have today, we are going to provide some further advice on common themes which emerge during the session. The session's being recorded today and will be available for download from the department's website, which is www.health.gov.au, and that'll be available in the coming weeks. All the resources mentioned today are going to be on that website too. So please check that out if you're looking for information around the subjects of the discussion today. You can also send specific questions to the Aged Care COVID Liaison website, email address, which is agedcarecovidliaison@health.gov.au. So with that, I'm going to hand over to Minister Colbeck for some opening remarks, and then Helen Grinbergs is going to take you through speaker to speaker this afternoon and handle question and answers. Thanks, Minister.
Thanks, Michael. Thanks, everybody. Thanks to you and your department, Michael, for establishing this event today, and thank you to Allison and all the other presenters who are going to be with us today. Can I also say thank you to everyone out there who's working in aged care at whatever level for the extraordinary efforts that you've put in over the last couple of years, and for the work that you've done this year, and I'll indicate the impact of that in some stats in a moment. But it's been a very, very tough period, obviously, in aged care. Focus of the Royal Commission has put a huge spotlight on the sector, obviously, and the response that the government put in place to the Royal Commission in the budget following the receipt of the report is obviously very important, but there's still a lot more work to do in that space. But also the impact of COVID, particularly in New South Wales and Victoria, has been quite significant, and there's an enormous amount of work that's been done off the back of that through the research and the assessment of the outbreaks that's been really important in getting us to where we are today. And the thing that needs to be recognised, I think, is the enormous amount of work that the sector have done in both preparing for outbreaks but also managing outbreaks, and also implementing all of the learnings that we've had, particularly from 2020. In 2021, we've had the benefit this year of vaccination, but that in itself has been a significant task to get arranged through the work that the department's done, and pay tribute to our team there in that sense, but also just in a practical and a logistical sense on the ground within aged care facilities. It's been a big job. So thank you for all the work that's been done in that sense. It has, however, really paid off. To you before, the statistics show the difference that's been made by vaccination, and also what I believe is a significantly improved performance across the sector in respect of infection control practices. Last year, of the cases occurred of COVID in community versus in aged care, 7% of the actual infections occurred in residents in residential aged care, 2,051 out of 28,000 odd cases. That was 7%. This year, the number of cases in residential aged care in comparison to the numbers in the broader community, and we still obviously haven't got to the end of 2021 yet, but that has dropped tenfold to 0.7%. That is a significant result, and a tribute to everyone working in aged care. And obviously, as I said, vaccinations made a difference, but also the management of aged care and the infection control that's been occurring in residential aged care has contributed to that. And last year, we were severely criticised for this, 75% of the mortalities that occurred in Australia occurred in aged care, 685 out of 908. This year, that number is down to 17%. So COVID still remains a dangerous infection. We still have to be extremely mindful of it, and that's the point of the conversation that we're having here. But of course, we need to, I think, pay tribute to the extraordinary work that's been done by the sector this year. And the statistics speak for themselves. Improved infection control makes a big difference, and vaccination makes a big difference. So thank you to everybody out there in the sector that's played a part in that. Firstly, getting the residents vaccinated, but also to the entire workforce who have effectively been vaccinated as well. It's an astounding statistic that we're sitting at 99.9% of our workforce in aged care having been vaccinated, and I think that gives us perhaps the best protected aged care residential cohort in the world, and the entire sector should be congratulated for that. Clearly, there's still more work we need to do. We need to remain vigilant. We've commenced the process now of applying and supplying boosters, both to residents but also to those in the general community who qualify for that. And I'd urge anyone who has got to the point where they do qualify to take up the opportunity for a booster. I think it's really important in the context of maintaining the protection for senior Australians, also for ourselves, for our families and our communities. But I think it's one of the unsung stories of aged care and management of COVID more broadly in the community. So can I say to you all, thank you very, very much for all of your efforts this year. Hope you have a good Christmas. We'll talk about that more in the forum as we go through towards the end. But thank you so much for your efforts in assisting us to manage COVID in aged care this year. Thanks, Michael, and obviously I'll be able to participate in the question and answer period later on and some closing remarks. Thanks, Michael. Thanks, everybody.
Thanks, Minister. And I'll now invite Janet Anderson, the Aged Care Quality and Safety Commissioner, to give us some perspectives on the experience in the past and what we need to be thinking about going forward.
Thanks, Helen, and hello, everyone. It really is great to have this opportunity of sharing a bit of time with you, and thank you for your participation. You might be expecting me to start with the quality standards, which is often where I do start, and I'd be reciting to you that there are 8 standards and 2 of them are particularly important, standards 3 and standard 8. No, I'm not going to start there. I'm going to start on a more practical footing, because if we have learned anything in the last couple of years, we've learned that the practical is the pass or fail. So you already know this, and I'm going to go through it again because repetition is key, as I and other speakers will tell you today. We start with, and we continue with, and we always go back to the outbreak management plan. Do you have one? Is it fit for purpose? Is it customized to your particular services, plural, in each and every aspect of their uniqueness? If you don't have one, and if you haven't drilled it, then you've got further to go than many of your peers, and a much more important job ahead of you than some of your peers. Outbreak management planning is thing one. There is no absence of resources available to you to get that sorted. And as I'm sure Patrick and Ian will tell you, it's about drilling it. It's not just about having it, but it's about making sure that every single staff member, old and new, understands it exists, understands their role and responsibilities against it, and can deploy quickly to their station, to what they need to do, not just to avoid or reduce the risk of an outbreak, but to respond to an outbreak. So that's thing one. Let me cycle quickly through the other things on the list. Communications with residents and their families. That's often put it towards the back of the list, but we elevate it up through the list, and it comes second after the outbreak management planning and plan, because the need to know goes through the roof. If you've had an outbreak, and many of you would have by now, you know that residents and families have a very, very high, almost insatiable need to know. So you need to establish an outbound call regime. You need to be able to accommodate incoming questions. And if you haven't thought that through, no time like now. You must be able to accommodate that, because they deserve that level of support. 3, workforce supply and training. We talk about this a lot. We talk about whether you have a sufficient supply of replacement workforce, if it's 30% or it's 60% or it's 90%. And the Commonwealth today will tell you or remind you of the services and supports which are available from the Commonwealth Department of Health. But have you done the contingency planning on losing a proportion of your workforce because they have to isolate, because the public health unit says they are close contacts and cannot remain on the roster for now? 4th, infection prevention control. Again, talking about training of staff, access to equipment, use of equipment, and all that comes with that, disposal of waste, PPE and so on. Have you got that sorted? Have you got your supply chains? What's your inventory like? How quickly can you replace stock if you have a high rate of burn because you are in the middle of an outbreak? Have you done the modelling, which gives you a sense of confidence that you can respond quickly if you have an outbreak in that regard? Cohorting, often misunderstood or poorly understood. Cohorting applies to both residents and to staff equally. It's about physical location on site and separation with as much clarity as you can muster between those who are positive to COVID, those who may be positive to COVID, and those who on the most recent testing are negative to COVID. If you haven't got a cohorting plan, or you feel that you are not able to cohort because of your physical layout, that's vital to know as part of your outbreak management planning, because you must have a plan B. If you cannot cohort on site, what is your plan B? And how do you activate the plan B? Monitoring residents for signs and symptoms. This is business as usual. Every single day that people turn up for work, they are checking on the residents' well-being, and as part of that, they're monitoring for symptoms. That becomes even more important, obviously, when the pandemic's around, where the virus may have entered into a service, and staff need to be watchful, constantly watchful. And it doesn't require clinical expertise to notice that somebody looks a bit under the weather. They seem to be developing a cold. They're a bit less responsive than they normally are. What's going on here? Let's ask a few more questions. Let's get somebody else involved who can make a diagnosis quickly if necessary. Then you have all the questions around screening on entry. Are you screening your staff? What form of screening is that undertaking? What about residents, visitors, I beg your pardon? Don't deny access to visitors where you are permitted to allow them in by virtue of the public health order, because the emotional well-being of residents depends on their access to family and friends. So being nuanced in your understanding of the public health orders, ensure that you are enabling access safely by family and friends wherever that's possible. So those are the big ticket items. Then you need, and then finally in this list, of course, is relationships with other stakeholders. What's your relationship like with the local PHU? How often do you talk with the local health services, and how well do they know you? Do they have geriatric inreach services who know your residents or your consumers? What about the Commonwealth Department of Health? They have a case management role. Are you aware of what they do in the event of an outbreak? Are you aware of your obligations to report an outbreak firstly to the PHU and then to the Commonwealth Department of Health? These are all vital. Let me move quickly to the Commission's role, which is where I started but moved away from. Our role is to monitor your response by way of reducing risk of an outbreak and then rapidly responding if you have an outbreak. Yes, we assess your performance, and we are most likely to take regulatory action when you're caught flat-footed. Think about that. If you're ready to move, if you can demonstrate that you've taken all reasonable precautions, the outbreak has occurred in your service, and you are not responsive decisively and effectively to that outbreak, then we will take regulatory action. But if you demonstrate you have a plan and you activate the plan quickly, then we will support you along that journey. We will help you problem solve. But we must be confident that you've got yourself sorted. We must be confident that you are capable and ready to move. Remember, it will always be a rapidly evolving scenario. Every single outbreak is different, but everyone has the common characteristic that it can change direction quite quickly. What you decided this morning might need to be adjusted this afternoon. So your leadership is all important. Who is in charge? Who is making the decisions? Who is being wise and informed as they make choices almost hour by hour sometimes about what needs to be done by whom and with whom? So let's go back to TORS. Strong leadership, a well-drilled outbreak management plan, and especially constant vigilance, even when the risk outside the door appears to be low. The COVID normal operating environment requires all of this to be taken on board as business as usual. And I know that sounds immensely challenging, but that is the reality. Incorporate it, embed it in the way you run your services. It will become more straightforward. It will become more predictable. It will become, if not easier, then easier to deploy, because you take it as part of the way you manage your services and your staff, and you interact with the consumers you have for whom you provide care. That's the new way we need to operate, and that's what the Commission is looking for from each provider. Thanks, Emma.
Thanks, Janet. And a reminder to people, you can put questions as we go into the Q&A facility, and I will try and group them up and ask our presenters towards the end of our webinar and ensure that we've got some time for that. I'll now pass to Allison Mcmillan, the Chief Nursing and Midwifery Officer, who will talk a bit further about infection prevention and control. Over to you, Allison.
Thanks, Helen, and good afternoon to all the participants, all more than 900 of you, which is fabulous to see so many people on this webinar. I am going to talk about infection prevention control, but I am just going to cover off on some additional aspects. I think that some have been covered, but I will. I think that, you know, obviously we can see in the news that Omicron, the new variant of concern, is in Australia. there is much that we don't know yet. What we do know is this is an incredibly transmissible disease. This variant is very transmissible. We're still looking and waiting to get better evidence around how severe is the disease if you do catch it. What is this impact on vaccines? And so there is much that we still don't know. And the evidence will grow in the coming weeks and we'll get a better understanding. But what we can see from overseas is very quickly this is becoming the dominant variant now, particularly looking and seeing the news out of the UK overnight, and it's growing very rapidly. So in an environment, as we all know, and for many of you we're seeing borders opening. We knew that as borders opened, we would see more transmission in our community. We would see the living with COVID and the increased numbers, and we are seeing that. So it's as important as ever for you all to be vigilant, to be prepared, as Janet has said, and make sure that you've got your systems in place. Please, now is not the time for complacency, however tired we all are, and however we would just really like this to be gone. So let me remind you that infection prevention and control is much, much more than just PPE. And Janet has well covered many aspects of this, but if you go back and think around the hierarchy of controls that you have to have in place, and your infection prevention control trained nurse will help you with those measures. But please remember, it is about making sure that your staff are vaccinated, that your new residents are vaccinated, that you've got controls in place for preventing COVID getting into your facility by that constant vigilance about reminding staff not to come to work if they're sick, asking visitors and checking, screening visitors and saying, please, if you've got any symptoms at all, please don't come. The reminder to everyone, of course, as we all know, get tested. Stay home until you get those results. It's also probably timely for you to make sure that all of your current staff, any new staff, have completed the online training. There's nothing better than a reminder through that training, just to keep all of those ideas very in the front of everyone's minds around the important principles of infection prevention control. Make sure that any resources that staff need are readily available. And remember some of those things that we've thought about and done during this entire pandemic. Don't let this holiday season, don't let your guard drop. Remember those communal spaces, remember tea rooms, remember the importance of cleaning, remember all of those things that we know we need to do, even in this festive season, we do need to be careful. And make sure that this is, the role of leadership in this is to re-emphasize, to reinforce, and to remind staff that these things are these things have kept us very safe throughout this pandemic. I think also that at this point too, is it's the festive season, visitation. Let's make sure you're very clear. Make sure that the family and friends of residents understand what your visitation requirements are. Make sure it's well communicated and revisit that so that you've got that constant reminder to visitors, families and friends around the principles about keeping residents safe. The industry code for visitation in residential aged care homes is there for you. It's on health.gov.au, and of course you can find it and it's readily available. So again, make sure that you're thinking about all of these aspects as we move, whilst we've got this new variant of concern that we're seeing emerging in Australia, and as we move into a season where the COVID virus will exploit any opportunity we give it to get into your facilities. So these are the things that I would remind you to keep front of mind wherever you are and whomever you are in an organisation. Thanks, Helen.
Thanks, Alison. I'll now pass to Jacob, who will talk about some of the Commonwealth supports that are available if you are in the unfortunate circumstance of experiencing an outbreak. Jacob.
Thanks, Helen, and thanks to the other speakers who have already covered off a lot of the important preparedness messages that I was going to cover. So just to reiterate what's already been said, the department has a great checklist that we've just revised and popped out, which has a number of these key messages for you to work your way through to make sure you are as prepared as you can be. If you are unfortunate enough to have a case in a staff member, a visitor or a resident, the Commonwealth will provide you with support. As Janet indicated, the first thing you will need to do is notify both your public health unit and the Commonwealth Department of Health. So that's aged care COVID cases at health.gov.au, and that email address is on our website. It's clearly set out in a document which is called the First 24 Hours Guide. So that's where I would point you to in the first instance. It's worth having copies of that printed and around your facility as well as ensuring that staff are familiar with what to do. This includes, as the name suggests, what to do in the first 24 hours of identifying a case. And there are some immediate steps. I think the most immediate is to contact the public health unit, who can then organise appropriate contact tracing, further testing, and the Commonwealth will appoint a dedicated case manager. So what we mean by that is someone from our state office who will be allocated to work with the facility, work with the public health unit and other interested parties to navigate the support that may be required. So that includes providing access to a clinical first responder. So what that clinical first responder can do is either come on site or do a consultation remotely, depending on their availability, and assess the immediate needs of that facility in terms of infection prevention and control measures, workforce measures, and leadership capability on site. The other thing that a case manager will often do is facilitate testing and connect the facility with Commonwealth-funded pathology services. So Sonic Health can provide in-reach testing capability, and that's at the frequency that both the facility, the public health unit, and the Commonwealth case manager will discuss and agree on the advice of the state government public health units. So they're kind of two main things that will happen immediately. And then the next thing that others have talked about is workforce support. So facilities need to do that planning themselves. In the first instance, have your backup plans, think about how you can transition to 12-hour shifts, for example, and other strategies to utilise your existing workforce. Part of what the clinical first responder will do is discuss and help with cohorting, both of residents and staff, and then work to identify the staffing needs to support you during the outbreak. They'll then connect with my team, who will look at surge workforce capability. So there is a limited pool of additional workforce staff, which we have access to, which we can support facilities with in the event that they are considered to be higher risk or higher need for additional staff. But it's important to think about the different roles that your staff can perform and what functions can be performed remotely while staff are furloughed. For example, some of those really important communications functions that Janet mentioned. And I think on top of that, outside of the direct supports during the outbreak with workforce case management, testing, clinical first responder, we also will support you with any out-of-pocket costs that you may incur in managing the direct costs of an outbreak, and that will flow through to our grant programs, which will remain open and available for applications up to 30 June next year. Thanks, Helen.
Thanks, Jacob. And it's with great pleasure I invite Ian Thorley, the Chief Executive Officer of Estia Health, and Patrick Reid, the Chief Executive Officer of the Illawarra Retirement Trust, to share with us all their experience having managed a number of outbreaks in facilities but also the exercises that they went through to stress test their outbreak management planning across their various facilities. Patrick, we might start with you and then go to Ian if that works for the two of you.
Sure. Thank you. And thanks for the opportunity. And hello, everybody. I suppose I'll reiterate a lot of the comments that have been made around certainly being prepared. So the outbreak management plans that we have now should be coming up on almost 2 years old. Hopefully you've done your planning and you have that plan on paper. We're up to version 31 of our outbreak plan. And obviously, as Helen pointed out, we had an outbreak of our own, which had resident transmission. So the latest incorporation of that plan has all of our lessons learned from that. So it is a live document, and I think treating it as a live document is important. It must iterate with your experience and as you learn, both your own learnings and those from industry. So if anybody does want to see our plan, more than happy to share it with people if they want to drop me a note. In terms of the key areas, as I said, outbreak planning is probably the key one, getting ready. And the way that we did test that was to run what we call the first 24 hours checklist at each site. We've got 20 sites that we operate. So within that is making sure that your staff know what their roles and responsibilities are in that first 24 hours and having a very clear checklist that they can run through, because when they're under pressure, to have that checklist means that they can actually articulate well to both staff and residents what's occurring, and then obviously get some preparatory work in place before those other supports, whether it be the local public health unit, whether it be the Commonwealth Supports, and others do actually land on the ground, because it does take some time for them to wind up. So the earlier you do get into that plan, the better, and I think having that checklist is a great start. Within that too, of course, pandemics and outbreaks are a bit like babies. They never come at midday on a Tuesday. They normally come on a Friday night or a Sunday or a Saturday night. That's when you find out that you have an outbreak. So having that plan in place and staff knowing what to do from the moment that they understand that they do have an infected staff member or resident on site is very, very important. I think as Janet pointed out, the other thing to get right is your communications. And that's between yourself and the LHD in your region, the public health unit, the Commonwealth Supports that you may have as well. Understanding who's who in the zoo is very important. But even more important is your residents and their next of kin. So we had a process where we would ring each affected resident's next of kin every day with an update on their loved one, how they were travelling. But also too, we were putting out written communications via SMS, email and paper as well as required every day. It got to the point where you know you're doing it right when some next of kin and residents are saying they don't want to receive other communications every day because you've done such a good job of keeping them abreast. The other thing that we did use was OPAN, using the OPAN service to let the residents and the staff join a webinar to ask any questions they have about COVID, about your response, but also to understanding what the process does look like. Because for us, it was a 30-odd day pandemic process that we had to go through from the start of the outbreak to when we came out of outbreak and they've been declared over. So it is quite a long process and communication will be key. Obviously, clinical management and resident wellbeing are two areas that you do need to prepare for. And I think everybody who's experienced an outbreak, and I'm sure Ian can attest to this, workforce is critical, but it's also the first point of failure. At our Tarrawanna site, we had 28 staff who were immediately furloughed, and that rose to 36 staff over the period of the infection. So in that kind of a scenario, you do need to make sure that you have a good understanding of your agency staff, who's available to you, what supports the Commonwealth can provide, and if there are multiple outbreaks in your region, as we all know, staffing is difficult even now in steady state, let alone when you do have an outbreak. So making sure you understand that, and things such as educating incoming staff who are not your own, there might be agency or Commonwealth first responders, about the residents in your facility, making sure that they know their needs and preferences, but also to any specific clinical issues that they may present with, so people are fully up to speed as best they can be. Within that too, of course, is staff wellbeing. Those that are still on the floor have a huge workload. They are working often 12-hour shifts, and as Jacob said, you want to move to 12-hour shifts as quickly as you can, and we did that. But that does lead to burnout as well. We had staff who were coming in, at 4 and 5 in the morning, staying through for that 12-hour shift, going home, having a quick sleep, have a feed, and they'd be back again the next day. They're real troopers. But it does lead to burnout, and it does lead to fatigue, which can be just as dangerous as anything else that you're going to encounter during an outbreak. I think supply chain is settled now. Early in the outbreaks, of course, we saw some challenges around supply chain, but I think most of us now have hardened our supply lines, so we are going okay. But also, too, the Commonwealth support in the stockpile was critical during that period. I think too, having an outbreak management team, as Janet said, you need good leadership. And that wasn't just me, it was Mia and Linda, Charlize in my team and others who were all very calm, very professional around dealing with the outbreak, and the team on the ground particularly. And we can have conflicting advice coming at you too. It can be from the PHU, the Commonwealth first responders and other experts that you may deal with. You do need to know that as the provider, as the registered provider, a lot of those decisions will actually fall to you to make that decision. You can't rely on external decision makers all the time. You do need to act upon the advice you're given. And having a robust discussion around those issues is important, and remaining professional. But it is something where you will need to have calm decision making at the height of any outbreak and critical decisions. I think too, as the Minister pointed out, vaccination has been a great boon for us in terms of responding. I think we had 11% of people succumbed to COVID during the outbreak that we had, whereas earlier in the thing was as high as 80% in some other centres. So for us, I think seeing that vaccination work was critically important and remains so as we head through our boosters or third dose process as well. I think the other thing to look for is making sure that you are doing as much prep around mask fitting, other areas of PPE, donning and doffing training. We did all of this constantly and still do. I think the biggest risk that we face at the moment is complacency coming into summer, and also too, as we see visitation ramp up, is making sure you don't lose sight of the fact that your infection prevention control activities need to remain very vigilant and very active, and also too, screening of visitors and others as they come in. And that can get difficult because we've been going through this for quite a long time now, and reinvigorating that can be hard. So within that is making sure that you do have good processes around making sure everybody maintains their vigilance leading into the visitation period for Christmas, and also to into the new year when you may have lower staff levels because of vacations and other things over the summer. And I think for us too, just in terms of some of the challenges is around role flexibility, making sure that you are pulling in external resources that you may have within your business. It could be admin staff, it could be CNEs, it could be other people on staff who can act as proxies around PPE spotting, around fit testing for staff at the front door before they go in, RAT testing if they are APRA qualified. Now we also have home tests, which is advantageous, and making sure that you are utilising all those other supports that might be around you and not discounting them because they're not professionally trained. You can train them as required to do those roles as well. And I think for us at the end of the day, it is about cooperation and collaboration with those who are there to support you. We were very fortunate. We were supported very strongly by our local health district and a PHU. We'd also made sure that we had acquainted ourselves with all the systems in place. So when we did have our outbreak management team, which incorporated the state agencies and the federal agencies, everybody knew what their role was, and we clarified that over that period. There were still lessons to learn, hence why we have version 31 of the OMP, but please make sure that you understand who can do what and what the scope and limits of their role is. So you're not hoping for something that will never come, or vice versa, you're not taking full advantage of things that are available to you. So there's quite a lot to be thought of, and I think everybody's done a fantastic job protecting our residents throughout the last 2 years, but there's still a lot to learn as far as we can see. And we will continue iterating in our plan as we learn more from both our other colleagues and also to obviously the overseas experience. So thanks and good luck with it all.
Thanks, Patrick. And just a reminder to everyone, we are recording the webinar, so others will be able to watch this later and go back to Patrick's presentation. There's a lot of interest in your outbreak management plan, Patrick. I'll hand over to Ian. Thanks, Ian.
Thank you, Helen. I can only commend everything that has been said before me as important information. Absolutely, if we follow what we've heard today, we'll be in good shape to confront any of the issues that might be presented to us. Janet talks about being well drilled, and I think, as Patrick indicated, this is an important thing to do when you have time before an outbreak might occur. Last year, Estia, out of its 69 homes, had 11 outbreaks, or what would now be also called exposures. And as a result of those learnings, at this time 12 months ago, we started a simulation process, and we looked not only at the initial 24 hours, but we developed a scenario as I look at it here in front of me, that starts with a nurse ringing in, indicating that they've got a headache, sore throat, and they're off to get a COVID-19 test through for the next 5 days. And what we have done is lay it out various scenarios where a sore throat converts to a confirmed positive COVID test and what you need to do to manage those circumstances. And we roll this out across all of our 69 homes because to have muscle memory is just so important. The things that I would commend in preparation is think about expressions of interest of staff from your other homes that might wish to work in outbreak homes, because as has been indicated, should there be multiple outbreaks in a particular area, surge workforce might be limited. So you might be looking at your own resources. In terms of infection control, practice that. Donning and doffing. Do that when you've got the ability to think through and have time to practice it. In regard to the operation and the coordination of your outbreaks, potentially prepare for having multiple outbreaks if you're an approved provider with a number of homes, and think about what your central resources need to do to be managing multiple outbreaks at any one time. I think I would really commend running simulations to activate your outbreak management plan. That 24 hours is really, really important. Think about cohorting, think about standing down of staff, think about the initial contact tracing that you might need to do. Expect that if you have an outbreak, you will need many more staff than what your normal roster would normally require you to have, as you have to do all of those additional things. In terms of infection prevention and control, think about the spotters that you might have to bring along to do that extra work to ensure that as you cohort your home, be it residents or your staff, that you've got additional infection prevention control staff to assist with that spotting. Assume that waste systems might come under pressure, and you might have to have redundancy programs for your normal waste removal services. As you think about cohorting, and if you're doing simulations, look at the plans of the home and think about how you can separate your staff into different zones. And once a resident has got a confirmation of a positive test, or multiple residents have tests that turn positive, think about how you will create cohorts for infected and non-infected residents. Think about how you have to prepare a resident to be transferred with all of their goods and their personal items from their normal room to another room, and how you might have to have storage capacity. They're the very, very practical things that if you run simulations and work through all of those eventualities, should there be an outbreak, that trial run, the preparation, the learnings that you have in doing the simulations, I think will be well rewarded. Communications, that's been mentioned on a number of occasions. That cannot be overstated. And as Janet said, it needs to be done early in the piece. And I really, as Patrick has indicated, the greater the level of communications, the greater the trust, the greater certainty that you will create, not only with your residents, but importantly with their relatives who are generally removed from the circumstances. And also communications with your staff. Think about if there is a case reported, what do you need to do to communicate to the staff in the home, communicate to the staff coming on that next shift, communicate with your staff more broadly, because one of the things that is really, really important is for you to be the source of truth for all of your staff, because this can become very noisy, the media can get onto it, but if they know, staff know that you are the source of truth, you will build confidence, and that will support them to remain working and not have fear and run the risk of abandonment. So look, they're the essential elements that I would talk about. But as Patrick found and as Estia has found, simulations, hypotheticals are really, really effective ways of preparing for an eventual outbreak.
Thank you, Ian, and thanks again, Patrick and Ian, for your insights. There is nothing like hearing the real world truth and the experience on the ground, and those reminders around really stress testing outbreak management plans and taking the opportunity to do it again and again and again and refine as you need to go. We are sort of running close to time, so we've got about 5 to 10 minutes for questions. So I will move through questions as quickly as possible. But we will also, any that we don't respond to now, we will seek to provide Q&A on our website. Allison, I might throw the first question to you if I can, which is around the usual requirements around testing once you have an outbreak in a facility, what the usual practice might be, noting that this might change depending on the individual circumstances of the outbreak.
Thanks, Helen. So I think it will depend on the circumstances, you're correct. And really importantly, that any facility that has an outbreak needs to be communicating really clearly with the case manager and with the public health unit, because they are going to direct what that testing regime will be, and those instructions need to be followed, because we are seeing some changes in approaches, Helen, and obviously their likelihood is that the test will come to test all residents in a timely manner, but probably it will depend on the public health unit and the testing capacity in each of the jurisdictions.
Thanks, Alison. And I know in New South Wales, it has varied from daily testing in the first instance in an outbreak, or every 72 hours is a rough cadence as well that's sometimes undertaken. So it is very much dependent on that advice from the PHU. Jacob, there's a number of questions here around the processes that are likely to be followed in Queensland. I wonder if you can comment on our protocols with jurisdictions and where people can find that advice.
Sure, thanks, Helen. So the Commonwealth is working on finalising joint protocols on how we manage outbreaks in each jurisdiction. So for Queensland, some of the questions here go to things like staff furloughing requirements, transfers to hospital, testing frequency, and they're all typically matters for the state governments that we work with them on. On our website, there's a link to all state health guidance documents, and we'll make sure that in the next round of communications that we put out sometime this week, we have those links. But just touching on a few of these things quickly, typically in Queensland, I think the process is likely to be that residents will be transferred to hospital, but that of course depends on the circumstances of the outbreak and hospital capacity at the time. So it's worth factoring that into your thinking and planning and making sure that you have arrangements with general practitioners and other health practitioners to be able to support care on site. Similarly, contact tracing, there's a question there about that. And that is something which is the public health unit's responsibility. So the Queensland government will support you with that. But as everyone has touched on, understanding which staff, visitors, and residents in and out of your facility each day. So doing that tracking and screening of staff and visitors on entry is really important to be able to assist in those contact tracing efforts.
Thanks, Jacob. There's a number of questions in the Q&A that go to the difference in response in a home care or in community care environment in comparison to residential aged care. And much of what we have talked about today has focused in on that residential aged care environment. Janet and Jacob, I wonder if you can provide some reflections on how we might treat things differently in home care.
Yes, I'll lead out. It's a really well-placed observation, and it's one that can be overlooked. I think particularly for providers of home care services, they feel sometimes that the focus of attention is what happens in facilities, where in fact the imperatives that apply for providers of home care services are just as pressing in many ways, although differently configured. Quite clearly, what is happening in home care service is that the environment in which care is being provided is not a regulated environment insofar as it's a person's home, so the prescriptions, as it were, that apply to a worker are somewhat differently framed. Now, we would expect every single home care provider to have briefed themselves on the training, the guidance they provide to their workers, but also and particularly the communications that they have with consumers. Because we hear from time to time that consumers or their representatives have questions about, for example, the vaccination status of the people coming in, or do they have training? Will they be wearing PPE? What level of precautionary measures is necessary in order for this service to continue safely? Now, all of those questions are in frame for home care providers to address and be confident in managing in consultation with consumers and the people who represent consumers' interests. Clearly, it's a different configuration from that which applies in an aged care service or facility, but the level of obligation is not different in its intention, which is that the provider is obliged, just as they are if they're delivering residential care services, to ensure that staff are well trained and well equipped and supported to provide care in as safe and effective a way as possible, noting that the risks of COVID continue. Jacob, is there anything you want to add?
I was just going to add that on the Department of Health's website, there is a hub for home care resources. Some of the questions go to specific resources that people are after. There's a consolidated place there, and we can circulate a link to that later as well.
Thanks, Janet and Jacob. We've also got a few questions around vaccination, and Allison, I might pass these to you. I think the main question is will COVID-19 vaccination be a yearly requirement like the flu vaccine?
Thanks, Helen. Helen, the honest answer is we don't yet know. In recent days, we've seen that with the changing nature of COVID, we've seen, for instance, ATAGI change its recommendations around the booster shot, reducing that window from 6 months to 5 months. I think that it is very likely that we'll see some future need for regular vaccinations, but I think at the moment what we need to concentrate on is making sure that those that are everyone is eligible, of course, and we're in the near future bringing in the 5 to 11s, but that everyone has access to the vaccine and is getting vaccinated, and those that are now due for their booster, as we're calling it at the moment, should be getting that in a timely manner. So concentrate on the vaccine requirements right now, and we'll work through what the future requirements are when we get a picture of this in coming years. But as I say, I suggest we may well see for some significant time into the future some need for regular vaccination updates for COVID.
Thanks, Alison. Minister, we've only got a couple of minutes left, so I might pass to you to make some final remarks. And there are some questions around sort of visitation in here. I know visitation is something that you've been very focused on. Over to you.
Thanks, Helen. And firstly, can I thank all the presenters, Janet, Alison, Jacob, particularly Patrick and Ian, for your very practical examples and stories of how you've had to manage the virus in your facilities. I think it's really good for people to be able to hear your experience in that sense, but also what you're doing to mitigate and make sure that your systems are in place to ensure best protection of your residents. And Patrick, thank you very much for the offer to share your outbreak management document, or the latest version of. I'm not sure that people will want to see all of the incarnations, but I think that's a demonstration of how vigilant you as a provider have been in maintaining the latest information, integrating that into the way that you operate, and ensuring that you've got the latest information. It is a big task. I acknowledge that. Thank you for that, and thank you to all of the other providers out there who are doing the same thing, and in to you as well. There is a lot of information that's available. I see the bids notices coming out on a regular basis, and I know that Janet also has done an enormous amount of work, particularly out of Victoria last year, where there were post-infection interviews done with everyone who had one, which was a fairly significant task, but all of the information and all of the learnings out of that was then put into the advice that was provided out to the sector. That on top of the research that was done by Alan, Lilly and Lynn Gilbert, who did some specific reviews. That information is also now public as well, but all of that was integrated into the advice and the way that we were operating in support of sectors. I think the key message out of today, and I suppose highlighted by the events of the last couple of weeks, is the requirement to maintain vigilance in respect of this. Maintain your systems, be prepared, practice while you have the opportunity to, so that if you're unfortunate enough to have an outbreak, those things start to come or become a natural part of the way that you go about your business. That will make it the easiest, and that will help you. And I think the other point that was made by Patrick and Ian is that you remain in control of your facility. You need to be prepared to make sometimes some very difficult decisions. And yes, I know that's hard. There is support out there for you to access, whether that be through the Quality and Safety Commission or through the department, or through the local PHU. And I think one of the things we learned out of Victoria is building the connections between the public health units, the local health providers, whether they be primary or clinical care, and the aged care facilities, was a huge advantage at the end of the day. And the work of the Victorian Aged Care Recovery Centre this year has basically just kicked into activity based on the learnings of last year, and a lot of things have just effectively automatically flowed because they've become built into the way that we work. So building those connections is going to be important. They will be really important learnings for you who are in states where there hasn't been significant outbreaks of COVID in the community. If there's COVID in the community, you are likely to see it, unfortunately, in your residential aged care facility, because you are part of the community. So all of those protocols around maintaining access for visitors, doing your appropriate screening, and all your other systems become very important in ensuring that the operation of your service provides the best possible protection for your residents. I'll reinforce again the positivity of vaccination. And here I will commend the work that Ian Thorley did at Estia, where they went out with those of their residents who refused vaccination, had a clinical discussion. So a nurse had a conversation with the resident or the family to suggest the importance of vaccination. They didn't get everybody, but they got 50% of those that hadn't been vaccinated. That provides strong protection, again, for that person, for the residential aged care facility, but also more broadly. And we know the numbers that I quoted earlier showed, and Patrick mentioned in his comments as well, the survival rate in 2020 without vaccination was about 64%. The survival rate in 2021 with vaccination is about 86%. Vaccination works and is a strong support. So for all of you, for your staff and for your residents and those you're providing service to, advocating vaccination is going to be really important and make a big difference. But again, in concluding, can I just say thank you? I know that it's been a really intense couple of years. All of the people sitting around this virtual table, all of the presenters have all seen that close up firsthand, had conversations with families, been involved in outbreaks very closely. We understand how difficult it is. Mitigating the opportunity or the possibility of outbreaks is the best way for us all to go. So having the systems in place to do that becomes really important. It's the best protection that we can have. But thank you all for your efforts. It is genuinely appreciated. Let's hope that as the community opens up, we can continue on with the strong performance that we've shown over 2021, and wish you all the best over the festive season, and all the best for 2022. And thanks very much for being part of the forum today. I think it's really important that you've taken the time to participate this afternoon. Helen, thank you. Again, thank you to the other presenters.
Thank you, Minister, and thank you again to all our presenters. We will now close the session. A reminder that we will be publishing this on www.health.gov.au as soon as it is available. And there are also lots and lots of resources there for residential aged care providers, for home care providers, for community care providers on the response to COVID, including links to state and territory protocols as well. Go well. I hope you all enjoy your festive season, and thank you again for all that you do to look after other senior Australians in your care.